Hi everybody, this is Kim Elia and welcome to a very special session on the New World Veterinary Repertory with Richard Pitcairn and Wendy Jensen. So the format for tonight's presentation will be as follows. First we're going to have a formal presentation from Dr. Richard Pitcairn and that'll run for about 30 minutes. And then following that, Dr. Wendy Jensen will present also for about 30 minutes. And then after that, there'll be about 20 to 30 minutes available for questions and answers. So if you look on the right-hand side of your screen, you'll see there's a little control panel. And you can see there's a little place here for questions. You can go ahead and open that little part of the control panel and type in your questions. You can do that right away if you'd like. And throughout the presentation, I'll be taking record of those questions. And at the very end, for the last 20 or 30 minutes, I will read those questions verbally to Dr. Pitcairn and Dr. Jensen, and then they will verbally respond to those questions. So again, first presentation will be Dr. Pitcairn, then Dr. Jensen, and then there'll be a period of time at the very end for questions and answers. Before I pass it over to Dr. Pitcairn, let me go ahead and introduce Richard for everybody. So Dr. Pitcairn graduated from the Veterinary School of the University of California in Davis in 1965 and entered private practice in Southern California where he was working with small animals, farm livestock, and zoo animals. And then in 1967 he accepted a position at Washington State University in Pullman, Washington as an assistant professor and later entering graduate school with a major in microbiology and immunology and a minor in biochemistry. And this was all completed in 1972 with a PhD degree in microbiology. Following this, Dr. Pitcairn worked as a faculty member at WSU, active in research and teaching in the veterinary school. During his research on the factors affecting natural resistance to disease and the importance of optimal nutrition became a focus in his work. Realizing that such research would not be funded, he re-entered private practice to apply his study of nutrition and its effect on immunity and thus resistance to disease. During the years of clinical work, Dr. Pitcairn, along with his wife Susan, in 1982, published the first edition of Dr. Pitcairn's wonderful book called Complete Guide to Natural Health for Dogs and Cats. This book is now in its third edition and has sold over 400,000 copies and has been translated into several languages. So wonderful work. Dr. Pitcairn's primary sources of study when he turned to homeopathy were Hahnemann, Kent, Yar, Nash, Clark, Berkey, Dorothy Shepard, Carol Dunham, Ernest Farrington, Pierre Schmidt, Bunninghausen, Henry Clay Allen, Timothy Field Allen, Herring, Barthel, Burnett, Blackie, Blackwood, Bozier, Borland, Close, a coterie of incredible practitioners. His favorites are Hahnemann and Kent above all, and then Bozier, Bunninghausen, Lippe, and Yar. In 1985, he moved to Eugene, Oregon to establish a practice devoted solely to use of homeopathy and nutritional therapy with animals. And during this time from 1985 on, he conducted several workshops on homeopathic medicine which were offered to the public. And then in 1992, he offered the professional course in veterinary homeopathy. It was a year-long postgraduate training program for veterinarians. By the year 2013, there have been 500 veterinarians who have been trained in this program. During this time, in 1995, Dr. Pitcairn and associates co-founded the Academy of Veterinary Homeopathy. This is the first professional organization of practicing veterinary homeopaths in the United States. And then more recently, Dr. Pitcairn, in association with Dr. Wendy Jensen, has developed the New World Veterinary Repertory, which is available in computer and book form, both in English and in German. And this is a major reference works that homeopathic practitioners use in their work with patients. And this is the first veterinary repertory of its kind focused specifically on veterinary practice. So with that quick introduction, I'm going to go ahead and pass it over to you, Richard.
All right, thank you, Kim.
You're very welcome.
Wonderful introduction. All right, excellent. Well, in this first part that I'm going to talk about, I'm going to focus on the idea behind the repertory that we finally put together, Wendy and I, because I realized as I went along, you know, that not all repertories are the same. There's different philosophies and different approaches And it was necessary, of course, for us to develop something that was going to be very practical. We had to think through what kind of approach we needed. So I'm going to talk about that. This project actually goes back quite a few years. I started out working with David Workington, who gave me material and got me started with it. But it was the sort of thing where I had other commitments, of course. I was in practice and I was teaching, and so it would be on again, off again, and then David would say by email usually, how's it going? And then I would start working on it again. But then finally Wendy Jensen joined the team, and I think we took about, Wendy can probably tell us exactly, I think we worked together about 3 years on this, and she kept my nose to the grindstone, so to speak, and we managed to finally get it produced, which is was a very satisfying event. So I'm going to start out talking to you about repertories in general, and then give you more an idea of how ours is structured. So let's talk about the purpose of a repertory. And if we think back about, you know, when they were first thought of as an idea, at that time, Kim could probably tell us an exact number. I would say probably towards the end of Hahnemann's career, maybe there was 100 remedies or so, something like that, that had been investigated and described in provings. And so I guess if you have a good memory, it was manageable. But for me, it would be hard, and probably for most of us, to keep all of that in mind. And obviously, the database was growing. And we had to have some way of organizing the information so we could find it readily. So that would be the first impetus towards developing a repertory. A second aspect that would soon be apparent is that we want to have accessibility. We want the information to be there, but we also want it relatively easy to access. Otherwise, it's not going to be a workable tool for us. And the last thing is the repertory then being the front to the materia medica in the sense of the portal to it, that we use the repertory to narrow down our remedy considerations so that we can then go to materia medica and more thoroughly confirm that the remedy is a good choice for a patient. So those are the reasons that I could think of why we would have a repertory. And of course, the source of information then, starting with Hahnemann at his direction, was that we have provings that these things were tested in people, healthy people, hopefully, most of the time, and that this information from the provings then was organized, of course, in the materia medica that we have, especially the very extensive ones like Allen's Encyclopedia or Herring's Guiding Symptoms. But the organization of the information from the provings is really the question. So I'm going to give you an example here. When I came up with this, I didn't search out anything particularly. I just opened up the book here that's mentioned, the Encyclopedia of Drug Pathogenicity by Hughes, which is really a 3-volume set of just proving information. And I just opened up, I thought, well, aconite would be a good place to start. I just opened up a page and used what came up. So it wasn't like I tried to select something that was particularly slanted one way or the other. So I'm going to look at aconitum, part of it. It's quite an extensive proving, as you can imagine, of many, many pages. I'm just going to talk about page 95, which is the one I opened. And here's a text extract from that page, a proving of Dr. Wurtzel, I guess is how you pronounce it. And it starts out here saying that he's 39 years old. It talks about his temperament, sanguine. I don't remember what that means exactly, but it has a little description here of his prior problems. It says when he was younger, he had some articular rheumatism, some toothache, and when he would get chilled, some diarrhea, but has been well more recent times. So he starts out on the 22nd of February, 8 in the morning. He takes 6 drops of the tincture of aconitum. So this was, I would assume it wasn't even a potency. It was probably just an herbal extract of the plant. And what happened was then he felt an immediate slight scraping in the throat for about 5 minutes, and that was it. So then the next day, the 23rd, at 9 in the morning, he takes 12 drops. It's getting braver. And it says somewhat more severe but transient scraping in the throat. And then about 11, suddenly giddy when he's walking, and then slight throbbing in the frontal region towards both eyes for some minutes. Otherwise, he was well, as he was also the next 2 days when he took 12 and 15 drops. And then it goes to March 6th. Well, I'm not going to read all of this to you. You get the idea, I think. But what he was doing here, which is typical, is he's repeating the substance to the point where he produces symptoms. Hopefully, not everybody does. But the idea is that he would produce symptoms, and these symptoms then would be collected eventually in a materia medica as awaiting clinical confirmation, shall we say. So I just took part of this. On this next slide here, you can see this paragraph here that I marked colored in red. You can see I'm just going to work with that one because there's so much here it would take us a long time to go through line by line. So I'm just going to work with this one paragraph, which is March 8th, where he took 20 drops. And you see what happened there. What it says in the forenoon, that would be, in other words, in the morning before noon, frequent vertigo. Then at noon, you see the colon there, so it separates the two fragments of the proving. At noon, he had slight chilliness that lasted until evening. And in the afternoon, he had a soft stool. Excuse me. That doesn't make sense, does it? But it says afternoon, a soft stool at night, frequent waking without dreams. And maybe it's a typo. I'm sorry. I didn't notice that until now. But then he says chilly feeling, the loose bowels, and the tickling in the anus lasted 3 days. So he got into more of a reaction here, obviously, after taking it for several days and taking a larger dose of 20 drops. And then the last thing was he developed 3 vesicles, 3 blisters on the tip of his tongue, which had a burning sensation for 4 days. All right, so I would like to take this information from the proving, and I want to take it to the repertory and see if we can find it there. Because you see what has happened in the production of the rubrics, the information in a repertory, is that we take the proving and it's broken apart usually. We'll see in a moment some variations of that. But you know, it's usually broken into different parts and put into the places where we think we could find it. So here on the next slide, you can see what I've done is just listed. I'll go back here. This paragraph here that we're discussing, I just put it in a list form. These are the same symptoms, but it's just a little easier to access. So let's make the supposition that we have a patient that has something like this. Of course, it had to be a human patient probably to have this much detail. But let's say we have a patient that in the morning has frequent dizziness, then around noon has chilliness that lasts a day, and then the soft stool at night with frequent waking without any dreams, and the chilly feeling and all that. Let's say that's what the patient reports to us. This is my problem. This is what's happening to me. I have these attacks of this. All right? So what I did was I went to Kent's Repertory, and I made a table here, and I took these symptoms, and I looked to see if I could find them in Kent's. So the first one is forenoon vertigo, that is dizziness in the forenoon. And the rubric that I found in the repertory was just that. In Kent's Repertory, it's vertigo forenoon. There's 25 remedies. I didn't list all of them. I just listed the first few. But you can see aconitum is there. Then in the next part, you see if I go back here in this slide, you see in that first line there, it says forenoon frequent vertigo. All right, can we find frequent vertigo? So that's the second row in this table. Well, there is in Kent's the same rubric, vertigo. Just vertigo itself, that is not forenoon, and there's 277 remedies. And aconitum is present in that rubric, but there is no subrubric for frequent, or anything like frequent, any similar words for frequent. Okay, so that didn't get carried over. Let's look at the next one. At noon, slight chilliness lasting to evening. We do find under the chill section, chilliness, 128 remedies. Aconite is present there, but there's no rubric for slight chilliness. There's no rubric for starting at noon and extending to evening. How about soft stool at night? We have a rubric for soft stool, of course, 203 remedies. And aconitum is in there. But there's no rubric for soft stool at night. There is, I'll just mention, I just remember there is a rubric for urging to stool at night, but that's it. It doesn't say anything about type of stool. Okay, here's another one. The last row here says soft stool at night. I used rectum urging desire at night, which I just mentioned to you, and there's 11 remedies. This might apply, in other words, because the proving said soft stool at night, so in other words, maybe it would be covered by urging at night, possibly, but it's not in there. And there's no subrubric for soft at night. Okay, carrying on. Frequent waking without dreams. There is frequent waking in the sleep section, 156 remedies. Aconitum is there. There is no rubric for waking without dreams. The next one is tickling in the anus. Another prover further down in the book had it as itching in the anus lasting all day, just as an aside. So we look at rectum itching. There's 153 remedies. Aconitum is present in that rubric. But there is no rubric in Kent for anus tickling. Kent actually cross-references from tickling to rectum itching. But pretty close, just not exact. Then we have vesicles on the tip of the tongue with burning. There is a rubric under mouth section for vesicles on the tongue. Aconitum is there, one of 73 remedies. And aconitum is in that rubric, but the rubric for vesicles on the tip of the tongue does not include aconitum. And the last one is vesicles on the tip of the tongue with burning. So I looked under mouth pain burning tongue tip. 53 remedies, aconite is there, but there is no rubric for vesicles burning tip of tongue. All right, what about what if we analyzed? What if we did an analysis using these symptoms that we're considering here, this paragraph of proving symptoms? I put them in as best I could in Kent's repertory, as you see listed here. And I just ran the analysis to see what, if aconite would come up. And you see here with the arrow pointing to it, aconitum is there, certainly, not very prominent, but it certainly appeared in the group that I could get into the slide. But you see, it would be difficult. We're beginning to recognize the difficulty of recognizing the pattern. Not so much that we can't find individual things. There is a limitation on that. But we could find quite a few of the details that we saw in the proving. But to find the pattern and reconstruct it is not quite so easy. What about the newer repertories? So what I did next was I did the same listing of symptoms, and I just compared repertories. So we're going to go through the same list here fairly quickly. You can see, for example, in the first row, I have vertigo in the forenoon. And if it was present in such a rubric, I put yes, as you see for Kent's. And I put a dash there if it wasn't present. And I compared, at that time when I put this together, I compared these 4 repertories: Kent, Boninghausen, the Boger edition, Synthesis edition 7, and the Complete Repertory 2009. So you can see that 3 of them had it, similar to Kent. But interestingly, now look at the next grouping here. Vertical frequent, vertical paroxysmal, chilliness at noon, chilliness slight, stool soft at night. None of the repertories had this, not even the more complete ones or the more enlarged ones. Waking frequent, yes, all the repertories had that. Waking but not from dreams, none of them had it. Anus tickling, none of them. Anus itching, yes, all of them. And then we have anus itching all day, no. Tongue vesicles with burning. Synthesis had it and Kent has it, but not complete, not Boninghausen. Vesicles at the tip of the tongue, Synthesis has that rubric and has aconite in it. Vesicles at the tip of the tongue with burning, none of them have that. Tongue burning, they all have that rubric with aconite in it. Tongue burning tip, 3 of them have it, but not Boninghausen. I hope that makes sense to you. I was just comparing to see how well the symptoms were carried over into repertories. So let's consider then, since we see that not all the information is there, let's consider then, let's talk about how our repertory is constructed then. Obviously, decisions were made by the authors of the repertories. There had to be some kind of a thinking there, some kind of strategy or philosophy of how the repertory was to be put together. So I'm saying strategy 1, as I'm labeling it here, the early ones, and examples of those are like NERS, Gentry's Concordance, Hempel's Yar, and there's a couple of others probably I didn't think of. They did it, as I'll show you in a moment, in a way that tried to be more complete in terms of the grouping of pattern. The information was organized, but each remedy had quite a bit of detail with it. It's usable. I do use these sources, and it's usable when there's not too many remedies in the rubric. And you can imagine if there's a large number, it's really tedious, as you'll see in a moment as I give you an example of that. It's slow to read, but the information is very valuable and sometimes simply a clue to a case you're working on. The other thing is, I'd say sometimes the descriptions they give of the remedies, some of them sound alike. It doesn't really help you a whole lot because the little description they give is like, well, that was like the one before. So here's some example rubrics. This one is from the Hempel Repertory that's based on Yar's new manual. And the rubric, what would be the rubric here, like if it were in Kent's or another repertory, is they call it integuments of the head. Kent would probably call it outer head, maybe scalp or something like that, but I think he'd call it outer head. So it would be integuments of the head, subrubric, that would be the section, subrubric eruptions, subrubric itching, and there's 6 remedies in this Hempel Repertory. All right, so these are the 6 listed here. This is the way they appear. The first one says, this is actually the remedies in the rubric, if you can follow the meaning here. Instead of being abbreviated like you see in Kent's with commas between them, this is how it's listed in the book. So it has itching eruption of the head is mercurius. Itching eruption on the hairy border of the nape of the neck, temples, and eyebrows is nature muriaticum. And then the eruption of the head smarts with little itching, that's phosphorus. Eruption on the forehead with a burning itching sensation is briticarb. Eruption on the hairy scalp, itching violently, is Baryta muriaticum. And small scurfy places on the hairy scalp with itching is calinitricum. So that's the rubric. And you see, it's nice in the sense that it kept some of the information together as a little pattern. So if your patient describes something like that, a sentence like that, you could indeed probably find it here. All right, here's another strategy. And that is to include as much detail as possible. In other words, let's take as much detail from the Materia Medica as we possibly can and put it into the repertory. And probably our best examples, contemporary examples, are synthesis and the complete repertory, because they're both working in that direction. Well, the downside of it is the rubrics get very large, as you can imagine. And I think also the grading becomes somewhat insignificant when you've got so many remedies. You know, the higher grade remedies don't stand out like they used to stand out before. If it's in a book form, it becomes too heavy to lift after a while, literally. Or you have to start using multiple volumes because the book is going to get so big. It becomes impossible to do handwritten analysis. There's just too many remedies to write down. And lastly, computer programs will work like McRepertory or synthesis, but the outcome of the analysis is just so large it doesn't become, at least in my hands, it's not really useful anymore. So here's an example, comparing to the one I just went over with you in the Hempel Repertory. Here's a rubric, the same rubric from the complete 2013. It's head, eruptions, itching, 61 remedies instead of 6. And obviously informative, there's a lot here, but many, many more remedies as you see. And it's not unusual in some of these rubrics in the complete synthesis, there's hundreds of remedies in a rubric. Okay, strategy 3, this is the last one. This is really the strategy of the Bonninghausen Repertory, which is the base of the veterinary repertory that Wendy Jensen and I put together. I realized after a while of working with this project, it dawned on me what the strategy was and the value of it. And you see here's the same rubric as we just went over for the complete. External head, eruption on itching, 10 remedies. So Hempel had 6, complete has 61, and Bonninghausen has 10. Well, I had thought for some time that the rubrics were smaller in Bonninghausen because they just didn't have the information or he just wasn't informed or something like that. I gradually realized that it was intentional. What Bonninghausen did was he put together rubrics that were more focused. And these were remedies then that were more confirmed from clinical experience as being indicated ones. And also that it's necessary when you use a rubric like this that the rubric, instead of just sort of being a notation of a symptom that may be present but may not be particularly outstanding, what you do in this with this kind of repertory is you match rubrics to the patient's symptom importance. And by that I mean that it's an intense symptom, it's a very persistent symptom, it's a peculiar symptom, but it's not just sort of an ordinary or what Kent would call a common symptom, okay? It's one that's important to the case. It's important because of these factors of its intensity, its persistence, its peculiarity. And the last thing is the analysis in using the Bonninghausen-Boger repertory emphasizes location, modalities, and concomitants. So I want to say a little bit more about that approach. Because Bonninghausen is the one that brought together a focus on these two things, modalities and concomitants. He found that modalities and concomitants were extremely useful in finding remedies in cases. And he would start with an important symptom, and then he'd bring in one or more of these other categories, if you will, of symptoms to identify the remedy. I'm going to show you an example of that in a little bit as we go along here. So he found that Bonninghausen describes in his writings that he gradually realized that the modalities and concomitants as they appeared in provings and also in patients could be generalized, usually with accuracy. What I mean by that is a patient may report a modality for some symptom, such as worse from pressure or worse from warm weather or something. He found from his work that that modality would very often apply to other symptoms of a similar region or a similar type if those symptoms appeared in that patient. I don't know if that's clear or not. We perhaps can go over this in questions. but he found that the both modalities and concomitants would be accurately extended to other symptoms that could appear in other patients. Concomitants, if you're not real familiar with that, were symptoms that appeared along with the other symptoms but seemed to not be particularly related to the center of the case. Here's an example in Bonninghausen of how in his repertory he puts these sections we're talking about in there. So you see under fever, these are the main headings of the fever section in the Bonninghausen repertory. He's got compound fever, pathological types of fever with, of course, a lot of subrubrics under this. Then he's got time, the modalities that are aggravating, the modalities that are ameliorating, and the concomitants. And then he's got heat, burning, and partial heat. So he's got these in a separate section. So, for example, if in the aggravation section, there might be some modality that, as I said, worse from, say, getting warm, and that would apply to all the symptoms in this section, in the fever section. Now, I'm going to give you here, we're almost finished here, and I'm just going to finish up with an animal case example. This is a cat, one of my patients long ago, Moses, a 5-year-old cat, had become recently ill. He is very lethargic. He's completely lost his appetite. If the person makes him stand, he cries out from the discomfort. He has not literally moved for 24 hours. He has a fever, 103.5, up to 105, it varies. The blood analysis shows a normal white blood cell count, normal neutrophils, but very low lymphocyte and monocyte numbers, which suggested to me that the cells are migrating to some extravascular site, probably an abscess or infection somewhere in the body. It wasn't obvious where that was. It could have been a bite, for all we know. You know, it's likely, probably something like that. There are other values that were elevated here for those of you that are interested. The remedy that cured the cat was Brownia, 30C, given as single pellets on a 4-hour schedule. He had 4 doses, at which point he responded clearly that he was improving. The treatment was stopped, and he went on to a full recovery, which we confirmed after several days with a follow-up appointment. So let's look at these symptoms in Kent's repertory. So you see what I did here is I used fever inflammatory. I had fever worse for motion because he didn't want to move. This is kind of duplicative, but I put it in also as that he's better from lying down. I make that assumption. And crying out, that is crying out from the discomfort. And you see that the second remedy there is Bryonia, so it does come up, certainly there, probably obvious to anyone that knows the remedy that this is the remedy indicated. But belladonna is just slightly ahead of it, as you see. Okay, so that's how it looks in Kent's repertory. Here's the analysis done in the complete 2009. And you see I've got fever, inflammatory fever, motion aggravates, lying ameliorates, screaming, shouting, shrieking. Same thing. Once again, Bryonia comes up as number 2. Interestingly, nuts comes up highest instead of sulfur. But look how many remedies are in all the rubrics. Again, Bryonia this is an obvious remedy in this case for anybody that knows the materia medica. But what if you didn't? What if the remedy wasn't so obvious? You see how many remedies you would have to consider. So we'll compare that now with the Bonninghausen repertory, where we're going to use this approach that I discussed a moment ago. So I used fever inflammatory. It's under pathological type, inflammatory fever. I have a modality in the fever section. Fever worse for motion, there's 22 remedies in there. And then I use a concomitant in generalities, inclination to lie down, 11 remedies. And then back to fever, a concomitant, crying out during the fever, you see? And obviously Bryonia comes up right at the top. Nux is there, like it was in the complete, number 2 position and so on. But this gives you an example, not that the remedy that you need always is at the top, but you can see how much more clearly Bryonia is prominent with this approach. It could be one of the other remedies. It could have been. It could have been Nux. Could have been Belladonna, I suppose. You know, you'd have to look at that. You have to look at Materia Medica. But you get the idea here of the difference in when you do analyses of how it looks using this approach, this type of repertory. So this repertory we put together, we used Bonninghausen's repertory as the foundation. We did some careful editing to remove human symptoms. We used the rubrics that Wendy Jensen and I thought would really be useful to veterinarians. We enlarged. We brought in mostly from Kent additional remedies to add to those rubrics. And then we retained the highest grade for those remedies. And then we actually brought in some other rubrics that weren't in Bonninghausen, mostly from Kent, but also from a few other sources, though again we thought would be useful for veterinary practice. So Wendy's going to talk to you more about this aspect of it, of the editing and so on, but I'll just briefly mention this to you. All right, so that's it. This is the world's first veterinary repertory. I hope it makes some sense to you, and we'll try to clarify any questions if there are any at the end, okay?
Quick point of clarification. You mentioned a few times that the foundation of the New World Veterinary Repertory is the Bonninghausen Repertory. Is it the Bonninghausen Therapeutic Pocketbook, or is it the Boger-Bonninghausen, or is it one of the early alphabetical Bonninghausen repertories?
It's the one edited by Boger or Boger, however you pronounce it. Yeah, that's the one we used, yes.
Okay, the Boger-Bonninghausen. Okay, good, just so that people are aware. Okay, excellent.
Yeah, the Therapeutic Pocketbook is very good, but it's really even more human-oriented, so I didn't use that.
Okay, good. Thanks, Richard. Okay, I'm going to go ahead and make Wendy the presenter now, and I'm going to, while I'm doing that, I'm going to also introduce her. So Wendy, be prepared. You should be coming on just momentarily. And Richard, I'm going to mute you out just so there's no background noise while Wendy is presenting. So Wendy, you can go ahead and click on Show My Screen if you'd like. So let me go ahead and introduce Dr. Jensen. So Dr. Wendy Jensen received her veterinary degree from the New York State College of Veterinary Medicine in 1987. She worked in a small animal practice, also seeing horses, sheep, and goats. Dissatisfied in 1990, she left practice and spent 4 years in the nonprofit sector. And during this time, she attended a lecture on veterinary homeopathy and was captivated by the medicine's logical, straightforward, and yet profoundly satisfying philosophy. She went in search of training and then attended Dr. Pitcairn's professional course in veterinary homeopathy before being certified by the Academy of Veterinary Homeopathy in 1994. At that time, she returned to practice, opening the Jensen Homeopathic Veterinary Practice. Meanwhile, after serving on the initial expanded board for the AVH, she became their journal's executive editor, continuing through its first 12 years of publication. She's also published numerous articles in holistic health, animal health magazines, and she's lectured for the AVH, that's the Academy of Veterinary Homeopathy, the Homeopathic Medical Society for the state of Pennsylvania, various breed clubs, schools, homeopathy study groups, and also health organizations. She's taught for the professional course and also mentored veterinary homeopaths in the course's online community for 4 years. Her latest endeavor, which she has co-authored with Dr. Richard Pitcairn, is the New World Veterinary Repertory, which is available both in book form and also in software. Dr. Jensen currently writes, lectures, plays violin, continues to practice homeopathy from her home in the U.S. northeastern state of New Hampshire, and we're really excited to have you join us. I think it's the first time you've done one of these. Is that right, Wendy?
It is, Kim.
Fantastic. Well, okay, so you got the reins. Go ahead and do your presentation. Again, please, if you have any questions, write them down in the control panel, and there will be some time at the end for questions and answers.
Thanks, Kim. Well, what started this whole thing as far as finding the name, we had to name it after Richard Pitcairn and I worked so hard on getting the repertory into fruition. We needed a name. So Richard came to me and he said, well, you know, we've talked about that I've brought the veterinary homeopathy back to the New World. So we were thinking of the Christopher Columbus's ships, the Nina, the Pinta, the Santa Maria, and then my husband chimed in. He said, what about New World Veterinary Repertory? So it stuck. So that's where the name came from. And it's funny because there's a certain resemblance, if you look, between Christopher Columbus and Richard Pitcairn. I think there's a certain resemblance there with the beard. So anyway, what I want to focus on, add a little...
I love that, Wendy.
I wanted to focus on a little bit more pointers to fill out, add to what Richard said about the organization, and then I have about 4 cases. I'll try not to go too long with them. The first thing is Kent has a general extremities chapter, and we do not have one in the New World. And so what we did with Kent's general extremities rubrics was put them in the posterior extremities chapter. So if you are working on an animal and you have a concern with the front end, look into the posterior extremities too, because a lot of those rubrics will still apply. We didn't want to add another chapter, and I didn't want to have redundancy within those 2 chapters. And the little icons here are taken from the 2nd edition. These are a little fuzzy because of being blown up for my computer. There's the hind legs of horses and the front legs of horses. Now the other point I wanted to make with our repertory is we equated menses with estrus. If you know your physiology, it's not the same as far as what the levels of hormones are, but as far as homeopathic prescribing, when a patient is producing a discharge, there's more similarity than if you're looking at hormonal levels. So if you have say you're working with dogs that you're breeding and you have a concern about their menstrual cycle, their estrous cycle, look under estrus, and because there's no menses chapter. So it's about when the patient has a discharge, not when they're coming into a fertile state. So remember, and this is under female estrus would be the section to look for. The last thing to keep in mind when you're using the New World is when you see a modality and it's already in the generalities chapter here, that has been approved by Bonninghausen as applying to the entire case, to the patient as a whole. He would often find particularities like Richard Pitcairn had mentioned that applied to a single symptom, and then Bonninghausen would notice, wait, he also sees that modality in another symptom. You know, pressure hurts for a headache and pressure hurts for a swollen foot. So he'd make certain modalities generalities. Now we didn't have that assurance with Kent. He had a lot of modalities, but they were specific. You know, maybe to vision, maybe to abdomen, to stomach, to rectum. So Kent's modalities were put into their specific chapter. So again, that we preserved Bonninghausen's general modalities and did not dilute them. It's very important in veterinary medicine to have the modalities. So I'll go to my first case. I'm going to just briefly cover these cases just to show how we use the rubric and I like to bring the repertory to life, so to speak, with real cases. This one's an acute case, Roxy. She's approximately 5-year-old, not intact, a spayed female Airedale dog. She'd eaten a walnut about 9 days ago. She'd had surgery to remove it, and this is when it was a friend of mine whose vet called and said, Wendy, she's still not recovering. She was fine for about a week, but the past 3 days she's not eating, she's coughing, she has a fever, and her belly's tender. And they didn't really want to go back in there, but that was going to be the next step. So in the New World, what I focused on was concomitants. And you can see that in fever heat, the chapter on fever heat, there's a concomitant section, and there it is. There's a cough during a fever. Now it's a very small rubric, so I did have it in there, but I'm thinking I could knock that out if it limits my remedies too much. Abdomen pain was definitely applied to her. Also that when she was touched, it would be worse. So there's a nice modality. You know, some dogs, if you have a light massage in the area, of course, if on the incision, it's going to hurt, but this dog hurt all over her abdomen. So that's important to know. She was lethargic. And here's another way of writing that there's a cough during the fever. First I found it in fever section, then I found it in the cough section. And it's nice because this one's bigger. What we also did in our repertory was have plenty of cross-references. So you might find, if you look under this one, you'd find the fever heat concomitants also in there, recommended as a cross-reference. And here, another concomitant symptom, cough along with abdominal pain. And then the general wound symptoms, which applied to her because she just had surgery, and that she wasn't eating. When that was worked up, there was a pretty clear winner at the top. Now, with any repertorization, always go to the materia medica, and I didn't have time in this short talk to, but that's what I would normally do next, is show you where in the materia medica phosphorus fits Roxy. So it's not just a formula, but this was a pretty nice, clear result. And here I wanted to show you that I was thinking of leaving out this rubric because fever, heat, concomitants, cough, dry, tickling without thirst, because it was only 6 remedies. But there's phosphorus. Phosphorus is still in there even though it's a very small rubric. So that was a nice confirmatory rubric for the remedy. So I gave her 1 dose, 30C, and found out that about a half an hour later she began moving around. She had a normal bowel movement, and then they told me it was a first since her surgery. It's interesting that a lot of times you get the information you might have wanted right away afterwards, because if you look for under abdomen ileus, that means the bowels are not moving, phosphorus is in there. So she ate, and then I got a note, she hasn't stopped since the magic white pills were given. That's a fun case. So I want to talk briefly about animal cases in general. Try not to go too far into guesswork, because we don't really need it, or we can get led astray by it. So you have plenty of things that animals can display that you don't really, I'm sorry, it keeps flicking forward. You don't have to guess. You can tell an animal's angry, they're irritable, they're fearful, anxious. You know, these are basic emotions. Jealousy, happiness, there's frustration, there's excitement. Plenty of information there. You don't have to guess. So I like to emphasize that the more we interpret or assume or guess what they're feeling and why they're feeling, you're going to get off track in trying to treat your patients. The same would apply to a non-verbal human patients, infants, people in a comatose state. So here's one quick example. You might be interviewing your client and they're talking about their dog being mad when they're late. And there's not much you can do with that. They're mad when I'm late. Well, it's a guess. So what you want to know is, what are they actually doing when they're mad when they're late? So he hides under the bed, he growls and bites me when I try to get him out. He waits for 2 hours and ignores me. And he doesn't do this in other situations. So that's more information than he's mad because I'm late. And here's a whole bunch of rubrics that I just typed up there when I was given that imaginary scenario. There's generalities, worse when alone, could be because he's been alone all day and then you come home. There's maybe he's been asleep all day and you wake him up when you get home. And all of these could be, you could be a sleuth and figure out which one applies best to him. You know, maybe it's just being approached. Maybe he just likes to hide. You know, maybe he's just irritable in general. So again, look at what you see and not what you're assumed to be the case. What do you see, hear, smell, and touch in your patient? And here's an important, talking about emotions for animals, one of my favorite rubrics in our repertory is under generalities in the aggravation section. And aggravation due to emotions, and these are all the emotions listed in the New World. The star means that there's sub-rubrics, so there's more specific descriptions of anger or vexation making the patient worse, fear and anxiety, fright, So there's a lot to work with without guessing. So I'll start the first case, and this is Kay. He's a Maine Coon cat, and I wrote up a pretty quick thumbnail of him. He uses his bulk to bully other cats. He exercises from the middle up, and let me show you what that means. That's the cat exercising from the middle up. You know, he's not getting up, he's just laying there. And the main reason he came to see me was a non-healing ulcer in his right eye, been about 4 months, with some swelling and squinting. He also had teeth problems with some inflamed gums. He was hungry often and, as a result, overweight. Hindquarter weakness. He howls in the carrier on the way to the veterinarian. Here are the rubrics for him. There weren't many, and you can see a lot of them are large, or a few of them are large. Extremities posterior, weak and weary, 219. He was overweight. He was clumsy. And then he also had the tears that would often happen when he had the ulcer, and then a specific rubric for the ulcers on the cornea. Here's his repertorization. There's 5 remedies that have all of those rubrics in them, and so the proper, what I did was studied the Materia Medica, and I looked for what was unusual about him and looked to find it in the Materia Medica. And calcarea was definitely the best fit. So he just got a 30C somewhere around the 17th of May, and by the beginning of July I got this note back that I like to write down the really positive things because it lifts my spirits for when things get hard for other cases. Miraculous, amazing, wonderful, eyes are beautiful. But what really made me jump up and down was that he was more playful and he was less aggressive. That's nice when that goes together with the main symptom getting better, because you know something more is happening than just palliation. So a couple weeks later, he continues to be better, and even by another 3 months after the remedy, his hindquarter weakness had improved. Sorry about this twitchiness on my screen here, dumped. And the last follow-up was March 2011. He was doing very well, had not had a recurrence. That's a nice case. And Kura, 24-year-old Arab mare. And I love this picture because she's quite good looking, but every time I'd go and see her, the ears would be laid back. So I don't know how, but somehow my daughter got this picture, showed her nice face. So what she had, if I can show it without the all of a sudden the screen moving, was a gray mare melanoma. It had been diagnosed with a needle biopsy. It was about the size, right in here, right in her throat latch area, of a little bit bigger than a pool ball. It's quite huge. So her case, she also had a large parotid gland that's in that area as well, but not involving the tumor. She had a yellow, moist, scabby eruption under her halter, worse on the right side. She'd tend to get a hay belly. She had a click in her shoulders when she'd first start to move. She was described as reserved. And during her heat period, she wouldn't allow her belly to be brushed. She was kind of irritable then. Then there was some earwax. And she also would get wind puffs, which is a swelling, a fluid retention of a sort in her rear fetlocks. And these were worse for exercise and worse for, using the client's words, cold, icky weather. Interestingly, she had that same modality for a colic episode. It was during cold, icky weather. She'd had colic some years back. So when repertorizing this, you can see that I wrote excitable. She tended to react to me in that way, and also, well, she's an Arab. A lot of them are that way. Thick discharge from your ears. Here's the swelling for her feet. And then the eruptions on her cheeks. There were no other areas where she had the eruptions. Oh boy. And then here's the swelling of her glands. That is not the tumor, that's the parotid glands were big, because I didn't specifically find a rubric that I wanted for that tumor. I used the whole rest of the case. And then the cracking in joints was most unusual. And then a couple more descriptions of her discharging eruptions. So when we put that into the MAC-REP, calcarea comes up pretty high. You see the analysis for calcarea is 100, where it goes all the way down to 60 for sulfur. Already there's 2 that don't fit. And calcarea did suit her in many ways when I read the Materia Medica. So October 2013, a 30C was given, and it took 3 weeks. We waited until we started to see that it was getting smaller. And by June, by that summer, it was just about gone. And then she had some swelling, which is interesting because it was in the area that she had the wind puffs, the swelling that was normally not a problem, and this time it came back enough to make her very lame. So I went right to some acute remedy, and that didn't respond, and it occurred to me that perhaps this is an exteriorization of her case, and I should go to the same remedy again. But unfortunately, as in the horse world often happens, she was slammed from almost day one with painkillers and iodine leg wraps and aspirin and light treatments. So we don't know what it was that helped, but eventually she got to the point where she was running in the field. So I'm happy with that result, that the tumor was not even to be palpated by that point. And if she ever came back to me again, I'd certainly look at calcarea. So she's got some more time left. So I had one other case. Shall I go ahead and I'll go ahead and zoom through that. Stazzy, another Airedale, and she came to me with the left front lameness. I think she's about 5 years old at the time. When looking at her whole case, she's very slow to get up in the morning. She twitches in her sleep and is very easily startled. And she had a tendency to get swollen red eyes with a discharge. And way back as a pup, she had hard to pick up stool. And that just means when you're going for a walk and you're supposed to collect the stool of your dog so you don't leave it on people's lawns, it's a pain with a very loose, sloppy stool, so hard to pick up. And there'd be a white mucus on it. And there'd be mucus strings when urinating also. These are both as a pup years ago. This lady had come close to euthanizing her because she was so lame, and yet she loved so much to run and get her ball. So she called me. Rubrics that I worked up for her startled easily. She described it as if you touched her in sleep, she'd jump up as if the hounds of hell were after her. Quite dramatic. You know, it's normal to be a little bit, you know, a deep sleep and a sudden touch, sure, you know, but when it really stands out, that's when you want it as a rubric. And we even had starting up in sleep. As I recall, she would sometimes do this without any reason, so that stood out for me. Restless sleep, she'd often moved in her sleep. We can say maybe they're dreams, we don't know, but restless we can definitely observe. And this is her lameness, the stiff, muscular, and fleshy part, because there were no bony problems. She'd been diagnostified up and down until they couldn't find anything in the bony area, so it was definitely in her muscles. And then here, her eye inflammation, her soft stool, even though it was from years ago, it's part of her case. And I put in the generalities because she had the mucus discharge in her urine and also in her stool, and I thought that could apply to the whole case. Now here we have a whole bunch of possibilities. You know, one didn't jump out at me. So again, lots of Materia Medica study. And it did take some time. This was not the very first remedy I gave her. We worked through, I believe I looked at sulfur first. But the final stages, sulfur gave her a little bit improvement, but then we did go to sepia. And it took about 10 days. She started improving. And by 4 months later, in October, she was a lot better. And we averted the worry of euthanasia that's always hanging over veterinary practitioners. If you don't do well, You know, euthanasia could be down the pike, which is a very tough thing to have in this field. But anyhow, that's a whole nother subject, so I won't go there. So, but anyway, so she was a lot better in October. If she says like this, I have no complaint. She even said rest is more harm than good. That is what had started to become more obvious, which helped me switch to sepia, because sepia is so much better with hard exercise. Once that came out more strongly, then I could see sepia. So she's running as hard as she ever has, and the last dose in her case was a 1M given in February of 2012, and 2 years later she's still doing really great. I keep in touch with my patients if I can. So those are cases. I want to just bring up that we've got a second edition of the software. It was really fun. We did the first edition of the software, and then we did the book, and in the course of doing the book there were a whole lot of things that we added. And so what we did was, after the book was done, we made a second edition of the software. So with the second edition, there's 723 added cross-references, which I love because I keep forgetting what was that one? It was worded just a little different. Oh yeah, there it is. And so I'll find it easier that way. And then there were a whole bunch of rubrics that we relocated, so that, for example, if there was a similar rubric under, or an exact same rubric under one section and also a very similar one in another section, we'd put them together so that'd be just to make it more, to make more sense and make things easier to find. So that was a lot of work. And then, as Richard Pitcairn had mentioned, we'd added even some more new rubrics. And we added definitions because it's some of the terminology is rather old, has been around a while, and so having the definitions in there was very helpful. So you know what is erythema, or what is strumus, and so having those definitions is very helpful. So I think that's it, and thanks very much for listening.
Wendy, thank you. That was excellent. And I especially made note of your treatment of your discussion about not trying to speculate too much when it comes to mental and emotional symptoms, because it made me think about the footnote to aphorism 213 in the Organon, where Hahnemann talks about the importance of mental and emotional symptoms, but then he describes them as very, very, it's not this whole pseudo-psychological, complicated, description. It's just very general. They're either anxious or obstinate or irritable.
Yes.
It's a very general description, and it also reminds me of that when Bonninghausen, I have it right here from his lesser writings, when he writes that with respect to the long and minutely detailed description of cases which occupy several pages, I cannot help remarking they look but too frequently like some historical romance based on fact in the main, but are vastly embellished in the accessories. And that's exactly what you're saying is, we do all this pseudo-psychological interpretation of the mental and emotional symptoms of our patients. It doesn't even have to be animals. Even we do it with human beings, and it can lead us astray. So I really appreciate that. And I think that's one of the reasons we have to go back and look at our original literature and read carefully Hahnemann, because he's so incisive and cogent about these various issues. So I really appreciate that, and the whole presentation was excellent. So thank you very much.
Thank you.
So, Richard, you are also unmuted. I don't know if you were able to locate because I know that you have some new icons for...
Yes, I have a couple of pictures, Kim, I can show.
Yeah, let me make you the presenter then, okay? And we do have some questions as well, but let me go ahead and make you the presenter, Richard, so you can go ahead and show those if you'd like.
Yes. First of all, what I was thinking is I'm just going to show a picture of the repertory here. Let me know, Kim, if it's not legible, because the print's too small.
No, it's fine.
Yeah, well, this is just a skin section of the repertory, the New World Veterinary Repertory, and I'm not showing the remedies, of course, just the rubric names. But you see all of the lines, like here under cancer, that are in blue are all cross-references. And so, as Wendy said, we're really put a lot of work into this. Look, here's color. We've got all these things that you can go to. So, for example, if you went up here, say fungus hematodes, see, it takes you over there, or you can back to generalities where we, to this one, look at all the, this is really an extreme, of course, look how many sub-rubrics, I mean, how many cross-references there are. But we put lots and lots of time into into getting these, and it makes the whole repertory so easy to navigate, because we can move back and forth and compare rubrics and so on. So I want to show that. And then briefly, I don't know if you can see it, because the way I set it up is kind of faint, but for example, it says, right here it says catalepsy, and then in parentheses, sudden loss of function, freezing of movement, excuse me. That's the definition that Wendy was referring to. So all of those that are in, on the same line as the rubric are definitions, and all of them that are below the rubric are cross-references, and I have them in a different color there. So I hope that makes sense.
Also mention about the difference between the semicolon and the comma.
What's that?
So spasms, clonic, jerks means that spasms is the rubric, clonic is the sub-rubric.
Okay.
So people can find it. Yep.
Yeah. Okay, and then I'm going to just show a couple of pictures here of the icons that we, for the second version of the computer module for Repertory. Here's one. I've blown it up a little bit, so it might be a little bit fuzzy, but you can see maybe more clearly what they look like. These are there are two versions. This is the one that emphasizes photos. And so it starts up here as mind, and vertigo, internal head, external head, just the same organization as Kent's, for example, but the sections of the repertory are represented by photos of different animal parts. This is the other version.
Richard, before you change screens, I love the fact that the cat's got a question mark on his head.
I know, isn't that clever?
That is very clever.
We spent a lot. We didn't actually do this. Wendy and I, of course, are involved in choosing and deciding how it should look. But we had a person, Meg Henkel, who was the artist, that spent hundreds. I think really, if I'm probably not exaggerating, say 100 hours, hundreds of hours, putting these together for us. So really a masterful job. So the other version is this. There's more like illustrations. And you can see, again, it's animal parts, very similar. But we're seeing it as more cartoony. I don't know if that's a good word to use, more illustrative than photogenic. So just, again, here's the photos more. And here's the illustrative. So when you buy the module or upgrade to it, you'll have a choice as to which appearance you like. You'll buy one or the other. You can't get both because they're different, they're different coding and everything. But they'll ask you if you want to have the illustrative version or you want the photo version. So that's it, Kim. That's all I had to show.
Thanks, Richard. That's great. Okay, so we do have some questions. Let me go ahead and ask some of these. Some of these questions, I'm not sure that they'll be quite appropriate. They're like questions specifically about specific animal cases, but we'll see. We'll go through it and see what happens. Anyway, there's one question here. The person asks, I'm wondering if there's anywhere in the veterinary repertory to find rubrics for dogs digging excessively and grazing grass excessively.
Wendy, you have an opinion?
Excessively does make me wonder. I think it's normal for dogs to graze a little bit and definitely normal to be digging. I guess I'd want to know more. There's some homework that you need to do about what is the digging for. Sometimes they want to be getting some cool ground. They're just hot. Sometimes they're frantic and obsessed, and they'll show that in other areas of their life. So you need to find out. So no, there's not a specific rubric for digging holes or eating grass. There is under stomach, I think Richard might be pulling it out. Yep. Desire for, and you can have desire for indigestibles, but you'd want to see them to be eating more than grass for that to fit. Yeah, desire for, I think. There it is.
Earth. Yeah. Well, I'll add to that, Wendy. The first one is it's very hard to interpret the thing about digging like that because, as Wendy said, it's normal. Does it seem extreme to you to put it in terms of that dogs in many situations are kind of captive animals? They're restrained, they're kept in yards, they're kept in pens, and it's very natural. Wild animal, the wolf, and animals like that, they have an aversion to being restrained and confined, and they will very much attempt to get out, to escape. And in nature, they'll travel. A wolf will travel 100 miles a day, perhaps,
Right.
and it's searching. So, dogs. Not all dogs are like this. Some of them. It's a large topic, and I have to restrain myself from going too far into it. But I'll say briefly, the dogs have been bred to lose some of these wild characteristics. They've been bred to be more juvenile. So not all of them show this, but there are some still that have, I would say, a normal desire to get out. And so often I won't consider that a symptom. If they're digging, they're probably attempting to escape, and I don't use it as a symptom. The other one about eating indigestibles translates most accurately into their stomach's upset. That's why they do that. They do that instinctively when they feel their stomach isn't right. They're trying to put in some roughage. They're trying to stimulate vomiting or stimulate it to pass through its bowel movements.
Yes.
So, but that doesn't tell you which rubric. I mean, it could be stomach pain. It could be stomach digestion is retarded. It could be, so on. You have to go a little further into it and try to figure it out. But that's why they do that.
Richard and Jenny, the person who asked the question asked if for the rubric for the symptom of digging, they asked would mind destructive or mind tears things fit, and then for grass eating they asked if stomach desires raw or desires vegetables would fit.
Well, we'll see what Wendy comments on this, but I would say first of all this thing about tearing up the grass and digging, I feel certain it's not a desire to be destructive. Concept of destruction. Doing what they want to do because they have a desire to get out, they have a desire to do something interesting. They're not trying to damage anything. The other one was, again, Kim, it was, about desire vegetables. Certainly, it's possible they need something. I mean, that's again, see, that like Wendy was saying when she went over her cases, you have to, when you work with an animal, you can't just assume things. You have to look at it more carefully. So it's certainly a hypothesis that the dog is desiring something other than the food it's given. Maybe it's given kibble crap, for example, and it really wants something more. It wants something fresh. It needs some vitamins. It needs some minerals. That's certainly possible. And there are ways to find that out by close observation and questioning. When did you want to add
Yes, simply to remember to look.
I don't see any questions on my my screen here. So
no, sorry guys.
There he is.
Can you guys hear me now?
Yes, I can
Hello?
hear you.
Sorry,
yes.
My internet connection slowed down, so I got booted out there for a second. So sorry about that. So okay, let's. There are some questions here. Let me go ahead and so one of the questions that's asked is, do you prefer to use general modalities, specific modalities, or both if present in the repertory?
Well, I definitely lean towards the generalities. I find that it does more reliably give me a better picture of the animal once I get to the highest. Once I get to the finish with the repertorization, if I've used generalities, the particulars usually lead me astray. I find very particular descriptions that are nice, but then the whole rest of the case isn't in there. So modalities definitely, generalities.
Okay.
Yeah, I would agree. I would go, I use what's most definable, and I guess I said earlier in my presentation, symptoms that are, that stand out. Ones that are very intense, ones that are very persistent, ones that are recurrent. You know, those are one, in other words, I interpret those things, what I just described. Those are, that's the propensity of the life force to bring that symptom out. It's important in the pattern that that symptom be present. That's why it's so intense, that's why it's so repetitive. So it's an important part of the picture, so to speak. So I look at the symptoms in terms of how defined it is. For example, let's say there's something wrong with the pancreas. I certainly would use a rubric for the pancreas. And one of the nice things about the Bonninghausen-Boger repertory is that in there are rubrics for location. So for example, I don't know if there's one for pancreas. I don't remember. I'd have to look. But for example, if you can't decide, or going back, say, to stomach, you know, the dog's eating grass, and you don't know whether it's inflamed or it's painful or what, you can't quite figure it out. There very well might be a rubric just for stomach location. Those are surprisingly useful in animal cases.
Definitely location, very helpful.
Mm-hmm. Very good. There's a number of other questions I'm going to ask, but I just wanted to mention to people, for people who would like more information or who are interested in purchasing the new World Veterinary Repertory for the MIC Repertory and Reference Works programs. This is a unique product for MIC Repertory and Reference Works. You can contact the Synergy offices. You can call them toll-free here. You can see their website. The toll-free number is 1-877-YES-KENT or 877-937-5368. All right, so Richard and Wendy, there's another question here. How did you determine eruptions on hairy animals with the New World Veterinary Repertory, thinking of eruptions on hairy parts rubric, working specifically with camelids, making determinations about scaly eruptions on a dry-skinned hairy animal has been a major challenge for me. Any tips using your repertory, which I do have?
I would say look at the whole case. You know, you can find maybe a specific rubric, but you've got to have the general characteristics of your whole patient in there, because you can get lost, especially with the differences among the species.
Yes, and I would say, I'm just looking here now in the repertory, but I'm pretty sure we didn't even put that in. Yeah, here it is on hairy parts, except the scalp. In Bonninghausen-Boger, there's 7 remedies. But we didn't put that in because it's not applicable. Animals are hairy, you know, so it's not going to really tell us anything. That's the kind of thing that we had to make decisions about. You know, if it's something that just doesn't translate to an animal's body or an animal's behavior or whatever, then we didn't put it in. That was the work we did in making this decision. So I would say, you know, that would just be confusing to try to use it that way, to me.
Okay, great. Here's another question. Please tell us your experience with renal failure in some animals. What remedies generally come up, and also share the strategy you take up.
Wendy?
Well, I don't have a list. I wish I did. Say, okay, here's what comes up, because every single case is different. It's really interesting how you go back into the case, into the youth, the puppyhood or kittenhood of the animal, and you find the differences in there from the other renal failure case. So I simply don't have a list of what comes up most often there. It is very responsive to treatment if you've caught it pretty early. You can make them very comfortable for quite a long time. So it's a wonderful modality for renal problems.
Yeah, I'll add to that if in the New World Veterinary Repertory, that one of the most useful rubrics is under kidneys, inflammation, chronic interstitial. That's the rubric, because that's a kind of kidney inflammation, at least dogs and cats get. I don't remember horses and others, but that's the kind of pathology, so to speak. We also have a rubric for chronic parenchymatous, but chronic interstitial is a really good one to know. But also remember that when you get into something like that, like kidney failure, that say for if it's a dog or cat, by the time they're in failure, it's quite far down the road. You know, they've been chronically ill for a very long time. And by the time they're in failure, they've lost a great part of that organ function. So you're getting into pathology. And yes, we have to use pathology sometimes, but it's not as good a guide as other parts of the case, because it's sort of like, you know, if you took, for example, you say you took 10 dogs that developed kidney disease, there probably wouldn't be 10 different remedies, but it might be, you know, 4 or 5 different remedies if you worked out the cases. Whereas when they get down to the end, when they just have uremia and the usual symptoms, it's very hard to distinguish any remedies at all. So usually, as Wendy said, you have to go by the other parts of the case. You have to go by the history. You have to go by the modalities and concomitants. That's the only way you can figure it out.
Excellent. Here's a couple of comments. Thank you. I loved to hear your cured animal cases. I'd be up for a couple of mini-week course to hear more cured animal cases and interpretation of Materia Medica for your animals. Thank you. And then thank you for putting in the definitions. Wahoo! Okay. And there's a question here. I think it's woohoo, isn't it? Okay, anyway. So there's a question about pricing. So the repertory can be purchased for $295, but you do have to own a copy of McRepertory because it's not a standalone product. It works in conjunction with the McRepertory software. So it's $295 as an additional module repertory which you would add on to the McRepertory program. And let's see, is the New World, yes, that's the same question, and you need to pay for it. Okay, did you create any rubrics from your own experiences with animals?
No, I did not. Well, that I put together, I'm speaking for myself here, and Wendy can say what she's done. I put together some that, and by that what I mean is some symptoms which are common and frustrating in animals need to have rubrics to apply to them, of course. And so when I put it together, what I did was I put it together, yes, on experience, but primarily from study of Materia Medica. So looking at other repertories, reading Materia Medica, and one of the ones I worked on the most was a very common problem in dogs is this condition of the ears where they develop redness and discomfort and odor and usually some kind of discharge, usually more of an excessive wax production that gets kind of oily or brown or black stuff will come out. In the conventional veterinary field, they call it yeast infection, which it is not, because all dogs have yeast in their ears. And it's not an infection. It's simply the yeast are there already, and because of the condition of the ear, the yeast are simply having lunch and having a good time. So it's really a misleading label to put on it. But what I called it, accurately I think, is catarrh of the ear. Catarrh is an inflammation of the lining of a part of the body. And that's what's happening here. There's an inflammation of that part with excessive secretion of wax and so on. So there is, in the New World, there is a rubric for ear catarrh. And I'll just look at it here very quickly. It's catarrh of the ear canal. There's 28 remedies. And below that, as sub-rubrics, are the acute phase, the chronic condition of this, which is 15 remedies. Then this condition with discharges, there's one for acrid and 7 remedies for excoriating. And there's one for earwax increased. And then it cross-references to earwax flowing and earwax secretion increased. So that's an example. All that was added in was really kind of, in a sense, put together based on our interest in that clinical condition.
Great. Okay, Richard and Wendy, here's another question. Do you intend to add the New World Veterinary Repertory to any of the other homeopathic software programs?
Not at this time.
No.
Okay. Is there a cost to go from the first edition of the New World Veterinary Repertory to the second edition?
There will be a cost Do you remember what it is, Wendy, what we decided on?
I don't remember, no.
I want to say
Sorry.
$50. I don't remember if that's right. Kim, do you know?
I don't know, no.
Okay.
No.
Well, we're
But,
almost ready to
yeah.
release it, so that'll all be worked out. I'm sure it'll be on the web page.
Okay, and again, people, please feel welcome to call the toll-free number for the Synergy offices. Again, that's 1-877-YES-KENT or 877-937-5368. I think we have time for maybe one or two more questions. Question is, which materia medica do you recommend specifically for the treatment of animals?
Well, I use mostly herring, but I've also started to look more in the chronic diseases, Hahnemann's chronic diseases, as well as his materia medica pura, just because his descriptions are very, often I can find the exact description of what I'm looking for in there. But herring's very easy to use and friendly. I think Richard uses some others as well.
Mm-hmm. Yeah, I would say I turn to herrings first. If those of you are not familiar with it, it's 10 volumes. But the advantage of it for animal work is the detail that's there. You see, again, the problem of making assumptions is to some extent addressed by looking into the materia medica and saying, oh yes, here's exactly what I'm seeing in this animal. Here's the detail. Going back to what I presented with a extract of that proving from for aconitum, we suppose a patient is a human patient that had that pattern. You see how difficult it would be to put it together from a repertory to fit that. In other words, to reconstruct that rubric would be difficult. But if you then had some guidance as to possible remedies and went to materia medica, you might read exactly that. I don't know if Herring's has it like that. I don't remember ever looking it up to see. But you see, when you go to one like that, then you start to see more complete. So I use Herring's first usually. Then my other one I use just about as much as Allen's Encyclopedia, which is another 10-volume materia medica. And then I go to Herring. I go to Hahnemann's chronic diseases. I like to use also. I like Yar's new manual. That's the one I have is an old set that I got quite a few years ago. I'm sure it's quite ancient. It's 3 volumes, and but it's a very and I showed you some example of that from the Hempel Repertory on the new manual. I sometimes use Gentry's Concordance, and I use I'm sorry, I'm looking at my bookcase, so probably not hearing so well. I use Gentry's Concordance. And I also, of course, look in Kent's materia medica and Nash's and some of those, but those are the sources I go to first usually.
Richard and Wendy, the printed book is available?
Yes.
Yes.
Okay. And any thoughts about the software version versus the book version? Any recommendations or suggestions about?
They're the same. Well, you know, I guess there's some leapfrogging. The book came out after the first version of the MIC Repertory module. So it has some, and the book includes then whatever else we did. We're always working on it. And as Wendy showed us towards the end there, all the things, all the cross-references and corrections that have been made. So the book does include some of those changes, relatively minor. I mean, not big, drastic changes, but certainly some continued editing. Then when this computer one's going to come out, the next version, it's going to be everything up to date that we've done since the book came out, right? So it's going to be like that, back and forth. You know, we keep trying to make it more accurate. We find errors now and then. We correct, you know, typos and things. So it's an ongoing project. And
I would like to add that I mean, I have a whole lecture developed on this, the difference between using a book and software. I would just, in a nutshell, recommend anybody starting to start with the book, because you just see the information much better. You get it in your mind better when it's the printed word on the page. You see the organization in front of you. And so I highly recommend spending a few years with a book and then go to the repertory on computer. You can also just start with the book, work up your case, and then all the busy work, you know, the hard stuff, the repertorization, once you can do on the computer once you've done with your thought process. It really makes it a lot easier.
Great. Okay, well, unfortunately, we're out of time. I'm sorry for those of you who asked questions and we didn't get a chance to ask them. I've probably got a few hundred questions in here, but I do want to thank everybody for your participation. And maybe Richard, Wendy, you'll join us at some future time to do another one of these sessions, and
Sure.
we can explore a little bit further. I want to thank you both for your time. I know you're both very busy, and we really appreciate it. And again, if anybody has any further questions, you can call the Synergy offices toll free at 1-877-YES-KENT. or 877-937-5368. Hope everyone's having a good rest of your day or evening. Richard and Wendy, thank you again, and look forward to talking to you all real soon. Take care, everybody.
You're quite welcome, Kim. Thank you.
Tim, it was a pleasure.
My
Bye.
pleasure.